Welcome back to Air Quality Matters and One Take. One Take, my take on a paper or report on air quality, ventilation and the built environment. One Take in that it's, in one take and tries to summarise for you a scientific perspective on something interesting in, usually 10 minutes or less. Because who has the time to read all these amazing documents, right? This week, the conversation around indoor air quality, mould and chronic illness has been back in the headlines. You may have seen that the high-profile public intellectual Jordan Peterson has, according to his daughter, been diagnosed with something called Chronic Inflammatory Response Syndrome, or CIRS, linked to mould exposure. Now, let's be clear, this episode isn't about any single individual's health, and we should be sympathetic to anyone who is unwell and searching for answers. What this news does, though, is it throws a very public spotlight on a deeply complex and highly polarised debate that's been simmering for years within medicine, toxicology, and the indoor environmental quality world. It's a debate that pits the lived experience of suffering patients and the clinical findings of a dedicated group of practitioners against the established consensus of mainstream medical and toxicological bodies. So, for this one take, I want to unpack that debate a little, drawing on a couple of key reports, one a critical academic review of the conflicting literature, and another a fascinating look at how the entire country, Australia, formally investigated this very issue. Because when a prominent figure gets this diagnosis, it raises questions for everyone about what we do and don't know about the health effects of water-damaged buildings. So what exactly is CIRS? Well, according to its proponents, most notably Dr. Shoemaker, who first described it in the late 90s, it's an acquired illness triggered by exposure to biotoxins. While that can include things like Lyme disease, the main focus is often on the complex mix of contaminants found in water-damaged buildings, mould, mycotoxins, bacteria, and so on. The core idea is this: about 25% of the population has a specific genetic predisposition, certain HLA genes for those interested, that make their immune system unable to properly recognise and eliminate these biotoxins. So while most people breathe them in and their bodies clear them out, for this susceptible group, the toxins get stuck, triggering a persistent runaway inflammatory response that affects multiple systems in the body. The symptoms are widespread and debilitating: extreme fatigue, cognitive dysfunction or brain fog, chronic pain, respiratory issues, a whole constellation of problems that can ruin lives. The proponents have developed a detailed diagnostic and treatment pathway, the Shoemaker protocol. It involves specific, though often non-standard, lab tests for biomarkers like transforming growth factor beta 1, a visual contrast sensitivity test to check for neurological impacts, and even volumetric brain MRI scans. The treatment is a rigorous multi-step pyramid, starting with the absolute essential first step, complete removal of the contaminated environment. This is followed by medications like binders to help the body excrete the toxins, and then a series of other steps to correct the downstream hormonal and immunological chaos. For the people who follow this protocol and get better, it's nothing short of a miracle. They have an answer, a mechanism, and a pathway back to health. And that, you would think, should be the end of the story. But it isn't. Because if you turn to major public health bodies like the CDC, the World Health Organization, or national medical colleges, CIRS is not recognised as a valid clinical diagnosis. And this is where the conflict really begins. Mainstream toxicological and environmental medicine push back on the fundamental premise of CIRS. Their argument hinges on the foundational principle of toxicology: the dose makes the poison, if you see my t-shirts. They argue that while mould and dampness are definitely not good for us, they are clearly linked to allergic reactions, asthma exacerbation and respiratory infections. The actual concentration of mycotoxins you can inhale in a typical water-damaged building is orders of magnitude lower than the doses known to cause systemic toxic effects in animal studies or agricultural settings. The argument is that there just isn't the biologically plausible mechanism for such low-level inhalation exposure to cause the kind of severe systemic illnesses described in CIRS. Furthermore, the scientific evidence base for CIRS is a major point of contention. The vast majority of the published papers supporting the diagnosis and treatment protocol originate from Dr. Shoemaker and his own clinical group. While they have published case series and some internal trials, there is a profound lack of large-scale, independent, randomized controlled trials, the gold standard for medical evidence, validating the diagnostic biomarkers or efficacy of the treatment protocol. In science, for a new theory to be accepted, it has to be rigorously tested and replicated by independent researchers. On CIRS, that simply hasn't happened. To the broader scientific community, this looks like a research group marking its own homework, which is a significant red flag. So you have this impasse. On one side, desperate patients and dedicated clinicians saying, look at our biomarkers, look at our results, people are getting better. On the other, the medical establishment saying, your proposed mechanisms is implausible and your evidence doesn't meet the required standard of proof. This is where the Australian government's inquiry from 2018 is insightful. They decided to formally investigate biotoxin-related illnesses, including CIRS. They listened to everyone, the patients, the CIRS practitioners, and the peak medical bodies like the Royal Australian College of Physicians. Their final conclusion was on policy and pragmatism. They ultimately sided with the established medical consensus, which you might think is not surprising, stating there was insufficient evidence for CIRS to be recognised as a valid medical diagnosis. However, and this is the crucial part, they did not dismiss the patients. They formally acknowledged the reality of their suffering and their acute need for medical guidance. They recognised that these people presenting with complex, debilitating, medically unexplained symptoms were simply falling through the cracks. So they recommended a compromise, the creation of a national clinical pathway for patients presenting with symptoms attributed to damp and mould. This pathway, published in 2023, guides doctors to take the exposure history seriously, but to manage the patients by first ruling out the known conventional conditions like asthma, allergies, and psychiatric conditions. It specifically advises against the use of non-validated tests, often used in CIRS diagnosis, and cautions against costly or unproven treatments. It's an approach that validates the patient's suffering while grounding the clinical response firmly in evidence-based medicine. It's a framework for providing compassionate care without endorsing a scientifically contested diagnosis. So where does this leave us? The Jordan Peterson case will undoubtedly drive a surge of interest and awareness in CIRS, and for those suffering from unexplained chronic illnesses, that attention might feel like a lifeline. It's important to remember that mainstream medicine can be slow to change. We saw during the pandemic how long it took for the airborne transmission of COVID-19 to be fully accepted against initial dogma. Science isn't static. However, the burden of proof for a new disease model is and should be incredibly high. The central problem for CIRS remains the evidence. Until independent researchers can replicate the findings, validate the biomarkers, and prove the treatment works in high-quality blinded trials, it will likely remain on the fringes, considered an unvalidated entity by the mainstream. This creates a self-perpetuating cycle, in my view. Without mainstream acceptance, it's very difficult to get the major government funding needed for big studies. And without those big studies, you can't get the mainstream acceptance. Perhaps the greatest value of a high-profile case like this is that it might just break that cycle, forcing a more urgent and focused research effort, and finally provide the clear, independently verified answers that so many people desperately are looking for and frankly need. And one thing that all sides agree on is that top of the treatment period, is the environment. Mold is not good, and remediation and dealing with the drivers of that environmental failure is always the first course of action. Sola dosis facit venom. The dose is the poison. Thanks very much for listening. Hope you enjoyed this episode of One Take. This episode is not possible without our sponsors, Safe Traces and Imbiot. Thanks a million. See you next week.